I've started the recording.
Okay, we'll just give everyone another couple of minutes where the traffic is starting to pick up. Hey everyone, we'll get started. I noticed that there are quite a few people who are still joining, but I thought that we could start with the introductions while people are joining on. So good afternoon, everyone. I'd like to welcome you to our Minority Health and Health Disparities in Neuroscience webinar series. This webinar series offers the opportunity to share research advances, lessons learned regarding cross-cutting challenges and opportunities in the field. And so it gives me great pleasure to introduce Dr. Yaquil Quiroz and Dr. David Marquez, who will serve as moderators for a very distinguished panel of scientists. Today's webinar is entitled Addressing the Disparities in Dementia Risk, Early Detection and Care in U.S. Latino Populations, Insights from the U.S. Consortium of Aging, Dementia and Latino Studies, or CADLAS. Before introducing our speaker, I would just like to let you know that at the end of the presentations, we will allow time for questions. If you do have a question, please type it in the question box, not in the chat box, in the question box, the Q&A box. And Dr. Yaquil and Dr. Quiroz and Marquez will ask it on your behalf. Now to introduce our moderators for the webinar. Dr. Quiroz is an associate professor in the departments of psychiatry and neurology at Harvard Medical School and Massachusetts General Hospital in Boston. She is the director for the MGH Familial Dementia Neuroimaging Lab and the Multicultural Alzheimer's Prevention Program. She earned her master's degree in cognitive neuroscience and a PhD in clinical psychology from Boston University. And her research interest includes brain imaging, genomics, early detection, and preclinical biomarkers of Alzheimer's disease and other dementias. She is joined by Dr. Marquez, who earned a doctoral degree and a master's degree in kinesiology from the University of Illinois at Urbana-Champaign, and a bachelor's degree in psychology from Loyola University, Chicago. He's a professor and interim department head of kinesiology and nutrition and the director of exercise psychology laboratory at the University of Illinois in Chicago. He's also the leader of the Latino Corps in the Rush ADC, and his research focuses on reducing health disparities. It primarily focuses on older Latino adults. He's also a fellow of the Society of Behavioral Medicine, the Gerontology Society of America, and the American College of Sports Medicine, and the National Academy of Kinesiology. So with that, I will hand the mic over to the moderators who will introduce our panel.
Thank you very much, Dr. Martin, for the invitation. Can we have the slides? Perfect. So first, we're going to start by briefly introducing the consortium. So you will hear more about this during the presentation. But the Consortium of Aging, Dementia and Latino Studies, or CADLAS, is a consortium we that we started over 2 years ago. This is the website if you want to learn more about the specifics, the CADLAS.org. Next. So the main objectives of the consortium are the ones that are here presented, but briefly, the main goal of the consortium is to actually promote or foster collaborations among investigators that are working with Latinos or Hispanics in the US, with the main goal of advancing aging, Alzheimer's disease, and related dementias research. We provide a forum for the discussion or the development of new collaborative studies or research. We are very interested in supporting the development of early career researchers or investigators, and everything with the ultimate goal of advancing the knowledge of aging, Alzheimer's disease, related dementias in the US Latino populations, with the goal of understanding the disease, the etiology, the diagnosis, prevention, and treatment of this population. And you will hear more about the work that we are doing in these areas. Dr. Markers, next.
Thank you, Yakil. Thanks all for being here. So our consortium is broken down into 4 special interest groups, and you can see them listed here: Genomics and Biomarkers, Cognition and Assessment, Dementia Care, and Psychosocial Interventions, and Recruitment and Clinical Trials. And then each of our groups, special interest groups, has either 2 or 3 co-chairs. You can see them listed here. And if you can go to the next slide, we are fortunate to have them as our panelists. So Jorge will be speaking first about biomarkers. We have Katia, who will be presenting on assessment, Jaime and Miriam on the psychosocial interventions, and Elena and Christian about recruitment. And so in the interest of time, we keep that brief, and I will turn it over to Jorge for his presentation.
Excellent. Thanks a lot for the intro and for the invite. And the main goal I had for today, it's mainly talk about genomics and biomarkers in Latinos. What are the main challenges that the field is facing right now, but also what are the opportunities that we as a group believe that we'll be targeting in the next years. Next. These are my disclosure. Next. All right, just a brief intro that will also serve for the rest of the presentation that you will all see today. It's just providing rationale why our group focus on Latino populations and Alzheimer's disease. And one of the main reasons is because by the year 2040, Hispanic population will face the largest increase in Alzheimer's disease and related dementia. And just to put it in perspective, if you see the graph, countries in Latin America will double the prevalence of Alzheimer's disease and related dementia in just 1 decade. So in other words, what took 2 decades to happen in North America and in Europe will only take 1 decade to happen in Latin America. But that's also true for the Latino community living in the States, right? And that's why it is so important to work with our population. And that happened in the context where we don't have still enough epidemiological research in our population. Our populations are still underrepresented, both in clinical trials for AD and other dementia and in research. And then there is limited access to research institutions for most of our populations. Next. Now, what are the main drivers, or what do we think that are the things that we need to take in care when thinking about populations, reaching out to them, but also thinking about genetics and biomarkers and how we enroll Latino population in our study? Well, first of all, it's how do we build trust in our population, right? And approximately 1/3 of Hispanic American has experienced discrimination with seeking help. So if you have experienced discrimination when approaching help, then that's a limitation also when you are being approached to being involved in research. The other thing that is important to address, right? How our population see us when doing research. And 9 out of 10 Hispanics believe that having someone that understands their ethnical, but also racial background is relevant. The other thing is how do we raise awareness? And that's something that our groups takes really serious, because still nowadays, 6 out of 10 Hispanic believe that loss of memory or loss of cognitive abilities are part of normal aging. So it's changing that awareness about the disease will be kind of relevant, because usually also our population come later to our clinics when seeking care. And the other thing that is relevant is that we know that there is a high risk in the Hispanic community, but understanding what is driving that risk will be key to answer those questions. Next. Now, as I mentioned, I'm going to talk mainly about genetics and biomarkers and where we are. Overall, in the last 2 decades, I believe we have done a fantastic work in understanding what are the main genetic factors that drive AD. But most of these studies have been done in US and European populations with little to no representation of Hispanics. So understanding how each of these variants we have discovered in the last 20 years impact AD in Latinos will be key to understand Alzheimer's disease risk from a genetic point of view. Next. And just to make that point, in orange, you see the numbers of studies that are coming from Latino community in terms of genetics, and this is less than 3%, right? So when we use polygenic risk score, only 3% of the information we are putting into those polygenic risk score are coming from Latino population. So we cannot assume that this polygenic risk score will work the same in preventing or informing future risks in our population if we haven't conducted enough studies in our populations. And just to illustrate that and why this is relevant, in the next slide, you will see Hispanic population are not a monolithic group. So having enough information about Caribbean or Mexican American may not be enough, right? We are not monolithic. We are a really genetic and mixture group. We have a continent where we have the confluence of African ancestry, European ancestry, and Native American ancestry. And that has a huge impact in how different variants impact AD. Next. Just an example, this is a research coming out from our group where we compare frequency and impact of E4 in Caribbean Hispanics, both living in the Caribbean US, but also with Mexican American. And as you kind of see, the frequency of E4s, it seems to be higher in non-Hispanics, Hispanics American and Caribbean, but higher in African Americans. Again, and the same trend we saw when studying Caribbean Hispanic, where the higher the African ancestry, the higher frequency of E4. However, the effect of E4 seems to be lower in those with higher African ancestry. Next. These multiple studies comparing the risk of E4 in Caucasian, almost 12 times if you have 2 alleles, but it's close to 2-3 times in Caribbean Hispanics with high African ancestry, quite similar to the results coming from the Yoruba study in people with high African ancestry. And in those with higher Native American ancestry seems to be higher, but again, not as high as those with high Caucasian ancestry. So here we are seeing a clear example of how the same variant impact AD in different ways, and that may be key when understanding genetics. Next. Just quickly, and just changing a little bit of gear now to biomarkers and where we are. I think we are in an excellent moment in AD and biomarkers. We now have a clear understanding of blood-based biomarkers, fantastic finding in terms of imaging biomarker, but especially in blood-based biomarker, a lot of the studies that we are coming is the same that we are seeing in genetics, coming from US and European population. So how do we use these biomarkers in our population, and how do we implement them in a larger scale? Next. Now, why these questions may be relevant, and one of those, it's, yeah, we know this is a really inexpensive way to understand AD, do early screening, both for early diagnosis, but also for inclusion in clinical trials in our population. However, at the same time, we understand that Hispanic population, they are different with other populations living in US and Europe. Number one, in terms of age, I already mentioned the impact of ancestry and how ancestry may play a role in these different biomarkers, genetics, and I just use a few examples of that, but also vascular risk factors. So what is the impact of vascular risk factors in biomarkers? We know that Hispanics usually tend to have a higher frequency of vascular coagulopathy together to AD. So how do we measure those biomarkers? What is the impact? Should we use the same cut points? Should we have more diverse samples when creating cut points for these biomarkers? And that's probably the case. That's why we need to include more Hispanics. Next. However, overall, I think that the future, it's clear, and we are overall, different groups are doing a fantastic work here. I just try to make a summary of the different groups that are working or at least collecting information in biomarkers in Latinos. And we have a mixture of studies both going in Latin America, the Caribbean, and US, and that will be key if we really want to understand. Now, one of the work our group will be focusing will be mainly on how do we harmonize across all these studies going, and that's a lot of the work that we as a consortium just aim to do, have this type of collaboration and agreement in terms of how do we cross-population comparison. Next. And that's my last slide, but of course, just thanks the consortium and all the members of the consortium, both with the biomarker working group, but with the consortium in general. And I will stay until the end for questions.
Thank you, Jorge. So now we invited Katia to continue.
Thank you so much. And thank you so much for the opportunity to talk to you today. So as Jacqueline said, we are the Cognition and Assessment Special Interest Group, and we hope to promote collaboration and advance research and assessment of US Latino populations. Next. So I want to begin by giving you an overview of some of the issues we need to consider when evaluating US Latinos. First, we are a nation of immigrants, and this is particularly true for a lot of Latinos, myself included. And immigration gives rise to characteristics that make us unique and represent significant challenges when evaluating US Latinos. These include second language acquisition, acculturation, socioeconomic stressors, and differences in level and quality of education compared to US-born non-Latino whites. Next. So Latinos display a wide range of proficiency in English and Spanish, depending on whether they were born in the US, like you can see in this slide, their age at immigration, and their time and experience in the United States. Now, currently, 68% of US Latinos speak Spanish at home, so clearly we need Spanish instruments to properly evaluate the majority of our Latino population. At the same time, the share of Latinos in the US who speak English proficiently or exclusively has also been rising. It is estimated that 59% of Latino adults in the US are bilingual. Now, this leads to the use of what we call Spanglish, participants mixing languages during conversation and testing. So to properly assess these individuals, we need bilingual testers and a standard way of administering and scoring their responses. For example, some researchers advocate for accepting correct responses in both languages to maximize test performance on cognitive tests. This can be done only when we have the proper resources. Now, more broadly, we know that language experience shapes the brain and cognitive function, and this is an active area of investigation for some of the members of our special interest group. Next. So another very important thing to keep in mind, as Jorge alluded to, is that US Latinos are not monolithic. We come from multiple countries and cultures and differ in terms of acculturation, racial backgrounds, and socioeconomic status. Now, people of Mexican origin represent about 60% of the US Latino population, followed by people of Puerto Rican, Salvadorian, Cuban, and Dominican descent. Now, how is this regional diversity relevant for assessment? Now, even though we share a formal Spanish, different countries have different names for certain objects. For example, light bulb is called bombillo in Colombia, lamparita in Argentina, and foco in Mexico. You don't want to diagnose a patient with a language impairment just because they're Colombian. So for those of you wondering why we can't just do a quick forward back translation when adapting instrument for US Latino populations, this is why. We need to recognize acceptable regional variations for adequate testing of our diverse population. Next. Oh, actually, could you go back one? So to take this a step further, and you can see on the right, the makeup of the US Latino population varies widely across the US. As you can see on the right, people of Mexican origin predominate in metro areas of the West, South, and Midwest, whereas metro areas in the Northeast tend to have more diverse Latino origins. Now, how does this impact assessment? We know that samples and populations will be different depending on your center. For example, what may be an adequate instrument for Mexican American participants in Texas may require different adaptation and norms for a Dominican population in New York. Furthermore, as with any sample, geographic location will impact opportunities and challenges for our diverse Latino participants. Next. So this next table, the one on the left, is a great example of the importance of asking the right questions when it comes to characterizing our participants. Now, according to the latest US Census, the number of Latinos who say they are multiracial increased dramatically from 3 million in 2010 to more than 27 million in 2022. Now, the main reason for this increase is simply a change in the census form that makes it easier for people to select multiple races. This is important as self-reported race is associated with identity, perceived discrimination, and as Jorge alluded, your ancestry can have some possible genetic risk for cognitive decline. Now, in terms of SES, we know that household incomes vary widely among Latinos, but overall, 18% of Latinos live in poverty in the US compared to 13% of all Americans, which of course has important implications for health and cognition. Next. So overall, US Latinos have lower levels of educational attainment compared to non-Latino whites, with 69% of foreign-born Latinos having educational attainment of high school or less, compared to 37% of all Americans. This has implications, of course, for assessment, and there is a strong association between educational level and performance on cognitive tests. Importantly, when considering education, it's not only years of education, but the quality of that education. Now, some of our Latino participants had inconsistent school attendance because they had to walk 2 hours to attend a rural school with few resources, or left school at a young age because they had to work. So our challenge is to find ways to measure literacy and quality of education in Latino populations, rather than relying on years of education alone. Next. So acculturation is another important factor to consider when assessing Latino older adults. Acculturation is defined as the modification of an individual's culture because of contact with a different culture. Lower levels of acculturation have been consistently associated with lower cognitive test performance in different cultural groups in the US. Now, cultural factors also influence an individual's approach to cognitive testing. For example, Latino participants may be less familiar with testing in general and often value accuracy over speed, consistently underperforming when assessed using timed tests. Next. So in terms of take-home messages, I hope I leave you with this. Given that 68% of US Latinos speak Spanish at home, we need culturally appropriate clinical and cognitive instruments in Spanish. As English proficiency increases, so does the need for bilingual testers and standardized instructions so we can adequately evaluate bilingual participants. Now, US Latinos are incredibly diverse, so we need to measure and account for linguistic, cultural, and other sociodemographic factors when evaluating older Latino participants. Similarly, we need appropriate population-based norms, as use of white non-Latino norms may overestimate cognitive and behavior impairment in older Latino adults. And clearly, more research is needed on sociocultural variables that can influence cognitive performance and rates of decline in US Latino populations. Next. So with this in mind, we established the Cognition and Assessment Special Interest Group. We are a group of professionals from a variety of disciplines and countries of origin that hope to increase collaboration and advance research in assessment of US Latinos. Next. So our overall aims are to create a community of researchers and experts on assessment of aging and dementia in US Latino populations. We hope to provide a forum to discuss the cultural, linguistic, and demographic factors that influence assessment of older adults, Latino adults, and provide guidance and education to the public on issues pertaining to the culturally appropriate assessment of US Latino participants. Next. So among our immediate goals, we developed a clinical and cognitive measure survey to learn more about common tests and questionnaires used to evaluate Spanish-speaking and bilingual Latino participants here in the US. We compiled a list of measures and questionnaires available in Spanish, which we then distributed among members of CADLAS, Latino ADC, and the International Neuropsychological Society. So far, we have responses from 13 cohorts and hope to obtain more in the coming weeks. Now, if you would like to participate in the survey, please use the QR code included in the slide. We would love to hear from you and incorporate your experience. Results from the survey will guide a manuscript on practical recommendations for evaluation of US Latino populations in research studies and acknowledge the help of participating sites. We also expect this to be the first step in harmonization of data across CADLAS. Next. Now, among our long-term goals, we want to provide guidance and education on culturally appropriate assessment of US Latino populations and create a central repository of publicly available instruments and norms for US adult and aging Latinos. We also hope to advance the study of cultural, linguistic, and demographic factors that influence assessment of US Latino participants by harmonization of data across the consortium and support of pilots for larger scale studies. And finally, we hope our efforts will eventually inform clinical practice and clinical trials. And I thank you for your attention.
Thank you so much, Katia. So now we invite Miriam and Jaime.
Well, thank you everyone for being here. My name is Jaime Perales-Buchalt. I work at the KU Alzheimer's Disease Research Center, and I'm co-presenting with Dr. Miriam Rodriguez from Indiana University. And we're both the co-chairs of the Dementia Care and Psychosocial Interventions, which is what I'm going to talk about now. Next one, please. Here's the outline. I will describe the background. Some of these aspects have already been discussed by the two previous presenters, but some of the stuff I'll be saying is new as well. And then Dr. Rodriguez will be talking about the introduction to the group and also some of the work that we've been conducting. Next slide, please. So dementia has a devastating impact, not just on people who experience dementia, but also their families, family caregivers. And that impact can be physical, psychological, and financial. Physically, compared to non-family caregivers, family caregivers have more stress hormones, just cortisol, more physical symptoms like pain, and higher medication use that can lead to polypharmacy. Psychologically, family caregivers tend to have more depression and anxiety disorders compared to non-caregivers of the same age and caregivers of people with stroke, among other conditions. To the right, you can see that family caregivers also, people with dementia also experience more financial difficulties compared to family caregivers of people without dementia. Next one, please. Latinos experience several barriers to care, and some of them have already been discussed. Latinos have the lowest median household income in the United States. They're also less likely compared to any other ethno-racial group to be covered by healthcare insurance. Next one. These ones, Dr. Ybriguera mentioned already. So they experience discrimination in healthcare. They also more likely to have misbeliefs about cognitive symptoms, thinking that it's a normal part of aging. And there's also an important value of their ethnic and racial background and experiences that they want to be considered when seen by their healthcare providers. Next one, please. And Latino families with dementia experience poor behavioral health. On the left, we're showing the prevalence of neuropsychiatric symptoms among people with dementia. In blue, Latinos, and in orange, non-Latino whites. And you can see how Latinos have a higher prevalence of basically every single behavioral and psychological symptom, more so than non-Latino whites. The graph in the middle is showing that Latino family caregivers are more likely to have depression compared to their non-Latino white counterparts. And at the time of diagnosis, but actually also 2 years before and 2 years after the diagnosis of their loved ones. And Latino caregivers of people with dementia are also less likely to access dementia caregiver support compared to non-Latino white counterparts. Next one, please. Miriam?
Thank you, Jaime. So I'll take over from here. This is our special interest group of dementia care and psychosocial intervention. We currently have about 12 to 13 members, and all of us have the same interest and the same research goal of examining Latino Hispanic caregivers of persons with dementia, factors that contribute to their burden, and interventions that can be most effective for that population. And as you can see, we represent institutions all across the country. Next. So we've decided to work on a state of science paper, and specifically we're interested in addressing the existing gap in culture and caregiver interventions that are considered cultural factors and are tailored specifically to meet the specific needs. Much of these needs were mentioned in the first half of this presentation of the Hispanic and Latino populations. So we're conducting a review of the literature, and we're looking at current caregiver interventions for Hispanic caregivers of persons with dementia. And we specifically want to answer the question, to what extent are health and social equity factors considered in the design, the implementation, and the evaluation of current Latino caregiver interventions. Next. We're using an evidence-based framework to guide our review called Progress Plus. This is a framework that was created by Cochrane Methods Equity. It's been incorporated into PRISMA guidelines for equity-focused reviews, and it's specifically aimed at reviewing behavioral interventions. So Progress Plus is essentially an acronym and used to identify characteristics that stratify health opportunities and outcomes. So things like place of residence, race, ethnicity, culture and language, occupation, gender, religion, education, SES, social capital, and then the plus just stands for any factors that weren't included in those previous factors, things like age, disability, and sexual orientation, etc. Next. So this table provides some examples of, we have a lot of literature, a lot of knowledge on how these factors affect Hispanic caregivers. And we're specifically interested in identifying how do current interventions address these factors. So for example, place of residence, there's evidence to support that Hispanics prefer to age in place. And many Hispanics live in rural areas and have less access to healthcare resources. So our caregiver interventions being created to meet these individuals where they are, rather than having them to travel long distances to access support and a helpful intervention for their caregiving burden. Are these interventions being created in the Spanish language? But more important than Spanish language translation, how are cultural factors, things like cultural beliefs, cultural values, how are they being considered in the development of these interventions? Occupation, so there's evidence to support that Hispanic caregivers are more likely to be employed full-time. So there's a lot of factors there that can add to caregiver burden, just the fact of having less caregiving time and having to balance work responsibilities with caregiver responsibilities. So are interventions being created to meet those needs? Are they flexible so that these individuals can access them outside of working hours? Things like gender roles, which place burden among Hispanic females generally to care for AD or AD patients. How is that gender role being incorporated into the design and implementation of these interventions? Religion. So currently about 80% of the US Hispanics identify as religious, and religion can be an effective coping strategy for caregiver burden. So are religious practices being incorporated in some of these interventions to promote coping? It was mentioned that Hispanics tend to have lower education levels, so this can affect health literacy, and especially for caregivers in understanding their loved ones' conditions, understanding and what to do and how to care for them. So can these interventions be created in a way that makes it easier for those of lower education, lower SES to understand and to optimize the efficacy of the intervention? The same thing with SES, with many Hispanics being living at the poverty level. Do we have interventions that are easily accessible for those populations? Are they affordable? How is social capital being incorporated into these interventions, with Hispanics relying more on family members for care and assistance? And then finally, other factors like age, disability, sexual orientation. So for example, Hispanic ADRD caregivers tend to be younger adult children. So can we create interventions that speaks to that generation more effectively? And then of course, disability and sexual orientation are areas that are very understudied in ADRD research, especially with caregivers as well. Next. So these are just references for all those facts that I stated in the previous table, and we hope to write a state of science paper that can just provide some salient recommendations for future caregiver interventions for Hispanic, Latino caregivers. Next. And that concludes our presentation.
Thank you so much. And with that, we pass it to the last presentation. Elena, thank you.
Thank you. Next slide. So I would like to talk today about the opportunities, challenges, and future directions to increase the representations of Latinos in clinical trials on dementia. And just to frame the public health crisis, Latinos represent 19% of the US population, and Latinos are 1.5 times more likely to develop dementia compared to whites. However, Latinos, Hispanics represents only a fraction of participants in clinical trials on dementia. For example, only 3% of participants in donanemab were Latinos, as well as aducanumab, and there have been some improvement because in lecanemab, 12% of participants were Latinos. Next. And I'm honored to co-chair the special interest group on recruitment with Christian Salazar. And we are both very, very honored to be mentored by Maria Aranda, who recently joined our special interest group. Next. And in my presentation, I will draw from the expertise of our special interest group, who include scholars, all committed to increase the representation of Latinos in clinical trials. Next. And in order to ensure that we hold the widest perspective, it's important that I will grant my presentation in the micro, meso, macro framework, so that we can look at the role of the major institutions such as funders, editors of journals, the FDA, in increasing the representation of Latinos in clinical trials on dementias. Next. And there have been very important milestones that paved the way, such as the National Alzheimer Project Act, and then the report Together We Make the Difference, and the diversity plans for clinical trials that are recommended by the FDA, as well as the funding opportunities to increase the representation of Latinos from the NIH, as well as the Alzheimer Association. Next. And one of these funding opportunities funded a paper that was published recently. And in this paper, we identified the barriers using to representation, as well as we formulated recommendations. And my slides will build mostly from this paper, and this paper has been endorsed by the special interest group. Next slide. So in terms of the community level, the very wonderful news is that one, we know what are the challenges, and such as, for example, competing obligations, or of feeling to be in a limbo in terms of information about clinical trials. But the wonderful news is that when these challenges are addressed, there is a strong willingness in Latino communities, in rural, urban areas, to participate in clinical trials on dementia. Next slide. And at the institutional level, so level of clinical trials, a major barrier is that there is a limited budget for efforts and resources to engage Latinos. And also there is a limited language capabilities of the staff for the clinical trial. And on the top of that, we noted in our, we implemented a multi-site intervention to increase the representation of Latinos, and we were successful to send Latinos, to refer Latinos to the clinical trial. This intervention involved the National Association of Hispanic Nurses and the Alzheimer Association. And so we found that we were referring participants to a particular clinical trial, but often the clinical trial struggled with, because I had limited staff to take calls and to follow up our referrals, as well as turnover of the staff. And then other barriers were the tight protocols of clinical trials in general that requires participant literacy, language proficiency, and then also onerous and frequent visits of clinic that are really hard given the competing obligations. And then also study partners makes it even difficult, and the incentives were often inadequate. And also relying the recruiting clinical trials often recruit via primary care physicians, but often Latinos do not have access to one primary care physician. So that's another problem. Next slide. And a major challenge at the macro level is that clinical trials that are not equipped, do not have strong plans to recruit Latinos, are funded nonetheless. And so that's a major problem that needs to be fixed, because that would have a major impact in increasing representation of Latinos. And also, on a related note, Latino executives are not often enough at the tables where important decisions on what clinical trials are funded, or what treatments are approved by the FDA. And also the anti-amyloid focus may have hampered the elucidation of other factors that are very important to Latino health, such as stress, like we heard, racism, pollution, and biological factors. Next. And so in terms of recommendations, number one, it's really important that that researchers of clinical trials, as well as funders, have a strong commitment to honor the representation of Latino throughout the design of the clinical trial and beyond. And so it's really important to shift and embed operation in Latino communities, hire researchers from those communities and pay them very, very well, and making sure that they stay in the clinical trial and engage with the Latinos, and then they want to participate in the clinical trial. So then the Latino participants feel welcome within the clinical trial. So the clinical trial is seen as a family of, and then it's important that the protocols to participate in clinical trials are simplified and expanded. And then in terms of incentives, studies from our special interest group found that providing healthcare services such as incentives for participating in clinical trials would make a really big difference, such as providing free eye check, blood pressure checks, blood tests. So that would be a really a wonderful opportunity. And then, of course, fostering information and transparency is essential. Next slide. And so lastly, it's really important that conference organizer and journal editors publish or agree to disseminate findings of papers that clearly inform what is the sample representatives and how what were the recruitment efforts to ensure diversity. And then it's important that the NIH continue to require robust initiatives and diversity plans in grant proposals of clinical trials on dementia. We recommend that the FDA, instead of only recommending diversity plans for clinical trials, that they make it binding. And then it's really important to think about the amyloid focus, that to expand research initiatives to include diverse cohorts and etiologies based on what matters most to Latino communities. And then it's important to support legislations that increase representations, such as ENACT. So next. So to conclude, it's really important that we shift the science to look and examine the influence of macro factors at the level of sponsor, funders, and the FDA to understand what is the influence of these factors in increasing the representations of Latinos in clinical trials on dementia. Thank you.
And can you go to the next one? Yeah, thank you. And that concludes all the presentations. And I just want to say thanks everybody for joining, and please use the QA to ask any questions. We still have about 15-20 minutes for the QA. And if you want to get more information about the CADLAS, please go to the cadlas.org to learn more about the special interest groups and all the initiatives that we are trying to develop as part of the consortium. So we get one question, so we're going to start with the questions that we have so far and give some time to the audience to write the other questions. So this question is about disability, and what do we know about the link between hearing loss and dementia in Latino populations? Given the lower SES in that group compared to the other groups, if hearing aids are less accessible due to high costs, is hearing loss a greater contributor to dementia in Latino populations compared to those in the other groups? Anybody wants to answer that question?
I personally am not an expert in that topic at all, but I saw the question. I started searching the internet. Basically, there's a few studies that are cross-sectional. I have here in front of me 4 different cross-sectional ones. The first one that came to mind was the SOL study, the study of Latinos, and then the SOL Inca, which is a future version of that, or a sub-study within that that's led by Hector Gonzalez. And I pasted on the chat the latest paper that I found, because all the papers were like, longitudinal studies are needed. Well, I found the longitudinal study, which is the SOL Inca study, and that's the one I pasted there. From 2022, Alonso Mendoza is the first author.
I didn't see the paper that you posted in the chat. You posted in the, okay, there you go. Sorry. So yeah, but based on the experience, and this question is asked actually by Dr. Karin Sean. Hi, Karin, thank you for joining. So based on the experience, yeah, so some of the patients actually complain that it's very expensive to get hearing aids, and also like with the insurance, sometimes they're only allowed to get some of the very cheap hearing aids, and they are usually not the ones that they get more comfortable or easy to actually get used to wearing them. So unfortunately also sometimes they don't get access to the ones that they will be easier for them to actually get it used to, just make it more comfortable in general. So even if they get prescribed and they get access, sometimes the insurance, they don't get access. So there are a lot of barriers there to actually get it. So one thing that deserves more research is actually see, like, once they actually get it diagnosed, the hearing loss, and they actually get the prescription for that, like how many of the patients actually follow the recommendation to wear it, because what I have seen is that sometimes they just don't follow through with the recommendation, which of course increase the risk of getting it worse. And one of the papers that Jaime, I believe, we referred to, also found association with higher levels of glucose. So pretty much also increasing the level, not just with the hearing loss, but also with making the increased levels also for diabetes. So which is also a big risk factor for the Latino population.
Out of the cross-sectional studies, the 4 that I found, I think those 4 were looking at the association between hearing loss and cognition, so not dementia or not MCI. 3 of them found that association, and there's 1 that didn't. And then the longitudinal one found an association with cognition, cognitive decline, but not with MCI. And none of them, I believe, have measured dementia as an outcome, which would be an interesting future study.
Okay, we got more questions. David, you wanna lay down?
Yeah, sure. So the second one from Olga Rodriguez: is Alzheimer's disease really higher in the Latino community? Could this conclusion be the result of so little research in the community?
Yeah, and I could take initial thoughts on that, right? And I will say that what we could conclude is dementia in general, right? Not Alzheimer's disease as a biological definition. Dementia in general, it has a higher frequency in Latinos, and there is a lot of evidence for that. Population-based studies, both in Latin America and in US. For example, 1066 study in Latin America show a higher prevalence of dementia in the Latino community compared with European-based populations studies and US-based study, including only non-Hispanics wide. And we are seeing similar trends in US in general, and that's dementia, right? As an umbrella term. Now, how much of that is Alzheimer's disease? How much of that is vascular Lewy body or FTD? That's a question that it's unanswered. And I agree that it's kind of like a premature conclusion without having more study and include more biomarkers or systematic characterization of our population when doing epidemiological studies. So that's where I think there is not yet a clear answer.
And to add to that, I would say that specifically in the United States, I think that a lot of Latinos get misclassified either way because of the lack of appropriate norms. I mean, and we've certainly seen that, you know, using non-Latino white norms to classify impairment for Latino patients is not going to work. And so some patients get over pathologized using those norms. And then sometimes it goes the other way. People are hesitant because they understand that, you know, we need more work in the instruments and we need more work in the norms. And so they're hesitant to call MCI or dementia when it's pretty clear that the patient has some cognitive decline.
We have another question. Thank you for the response. We have another question about clinical trials from Katie Richard. Clinical trials, any reflections about the quality of Latino Hispanic inclusion in trials for large-scale FDA industry trials as compared to smaller scale NIH-funded trials? Evidence that either can help the other to improve? I was going to pass it to give a Christian. You want to give any thoughts so you can speak a little bit?
Yes, thank you so much. So I'm an epidemiologist, and I'm working currently at addressing specifically the issue of looking at the underrepresentation of Latinos in clinical trials. And as we know, Latinos, because the prevalence is higher of dementia, there needs to be more work in this area to really understand how much the new treatments that we're looking at, both from big pharmaceutical companies, sponsored by big pharmaceutical companies, and also NIH-funded trials, whether these treatments can be equitably benefited by the Latino community. And we won't know that unless there is more representation of Latinos. That's principally the reason why we advocate for more representation of Latinos in these specific trials. So so that's really the purpose of having more Latinos in these trials. And also, as we know, the Latino population is increasing in the United States, and there's more diversity of individuals from different backgrounds even within the Latino community. So there is a need to really understand how these different cultural factors, now Latinos are not one monolithic group. We have a lot of different subcultures, and how these subcultures actually influence the participation in these trials, I think needs to be looked at carefully, and to find out more ways to intervene and also to develop strategies and tactics that might be useful in improving the representation of Latinos in these trials.
If I may add something, I think that very rightly so, and I'm thankful for it, that everybody's pushing for, Latino representation in clinical trials. But then when you ask the companies or the sites, okay, so do you have the instruments in Spanish? No. Like no instruments in Spanish, or there's no staff that can test bilingual patients or Spanish speaking patients. So that's a major block in terms of having our Latino participation in clinical trials. And it's something that I'm not sure how we can get at and I guess hold companies and sites accountable for trying their best to enroll Latino participants in clinical trials with the appropriate instruments and the appropriate staff.
Yeah, and moving forward, it would be interesting to see how we can involve more of these meso-level factors into creating these interventions. I mean, I think that'll be a nice novel take in the interventions.
Thank you. I wanted to check with Damali. Damali, how much time do we have? Sorry.
We have another 3 to 5 minutes. We
Okay,
do go over 2 sometimes if you need to get through the questions. So
okay, so yeah. So David, you want to take the next question?
Yeah, sure. A question, a compliment first. Great presentation from Iqbal. I wonder, what is the prevalence of vascular dementia and/or VCID in Hispanic population compared to other kinds of dementia? Do you study vascular dementia separately than other dementias? If so, what is the guidelines for vascular dementia treatment? Thank you. I don't know, Jorge, would you You have
Yeah.
mentioned vascular.
A few consideration and where this gets more complex, right? One, vascular risk factors leading to vascular dementia, and then contributions of vascular copathology to Alzheimer's disease. Contribution of vascular copathology to Alzheimer's disease, we know that increase the rate of cognitive decline and rate of impairment. So overall, when assessing participants, well, we believe that this is a mixed dementia, including Alzheimer's disease and vascular and dementia. Management of vascular risk factors would be key, and there is evidence that control of vascular risk factors usually slow decline of when we believe that there is presence of copathology. Now, in terms of vascular dementia, well, we have a clear clinical definition of vascular dementia, like important vascular burden preceding the onset of cognitive decline. Then again, a key there, it's the management of vascular risk factors, right? Both hypertension, diabetes, AFib, if present, and that would be where I will usually focus on managing these patients.
There are a few papers from, it is pronounced Jaime Fitten, F-I-T-T-E-N, in California, that look at vascular dementia and vascular cognitive impairment in Latinos compared to non-Latino whites. They're usually non-population samples, so the type of sampling might be a little tricky there, but it's worth exploring.
And also the same, like NIA, and there is the one. There is a diverse VICD study that is like a cohort study that started maybe 2 years ago, that is actually trying to characterize how the vascular impairment is actually happening in diverse populations. So I think that we will learn more about this in the future. I think that this study is also in California. I'm trying to remember what is the part of California, but I will quickly search for the link and put it in the chat. But it's kind of like the diverse VCID is the name of the study.
Charlie the Carly study at UC
There you
Davis.
go. That one, yes, he's the PI. Thank you. I think that we have time for the last question. Is there like a final question? In the
Yeah, let's take one more.
There's a couple people, it looks like it might be helpful for those people to directly, email or contact the people that are part of CADLAS that you have a direct question for, since we don't have time, for more direct individual things. But there is one from Kavita, curious about access to the newer AD drugs and the Latino population. Anybody want to jump in on that one?
I could do a lot of assumptions to answer that question. I don't think we have enough data yet to provide a clear answer, but assuming they have access to healthcare, right? According to, as now as an approved CMS drugs, they should have coverage through Medicare. Now, the question is how many Latinos are having access, right? And then we need to answer how many of them are getting a diagnosis of AD. Again, according to the FDA level, early enough, right? CDR 0.5 MCI or CDR1 to receive the drug, right? And how many of them will also meet the inclusion exclusion criteria that were part of the clinical trial to be included and receive those treatment. I think that's data that will be probably coming, and I know the Alzheimer's Association it's doing a lot of effort to try to create a network and tracking who's receiving drugs and the main adverse events and other related elements in the clinical practice, right? So I think in the next few years, we'll probably be getting a more accurate number on who is receiving drugs and who is not.
That's a very good point. The lower healthcare, we've said it several times in our presentations, lower healthcare coverage, lower socioeconomic status or household income, a later diagnosis. So it's rare that we'll see Latinos with MCI or early Alzheimer's or mild dementia and all that stuff. It's usually later in time when they're diagnosed. So those three are definitely going to be barriers, in addition to, you know, language or any others that we've been mentioning. Very good points.
Okay, thank you so much. That brings us to the conclusion of our webinar. This was wonderful, and this is our last webinar for the year, and it's a wonderful way to close out the year. So thank you to all of our presenters, our moderators. Thank you so much, and to the audience for joining us. Let me just share my screen very quickly and put this into slideshow mode. To let you know that our next webinar will be in January of 2024, and we will be joined by Dr. Astrid Suchidaisi, who is an associate professor for clinical neuroscience and the director of the Brain Aging Study. So we look forward to hearing from her next year. So thank you all once again. If you didn't have your questions answered, we will capture these questions and share them with the panelists and the moderators, and they will reach out to you, or we will get back to you with those answers. So thank you all again, and have a great day. Take care.
Thank you again.
Thank you.
Thank you.